Hi, I'm Alicia Gonzalez, emergency physician and the clinical training director at the Bridge Center, a program of the Public Health Institute founded to make it easier for people to access healthcare when and where they need it the most. One of our goals is to help people in our communities stop dying from issues related to drugs and alcohol use. It's no secret that too many people are dying from drug overdose and harms associated with substance use in general. Thankfully, for paramedics and EMS teams, we have the opportunity to change that by adopting the bridge model in our approach to addiction care. The bridge model is simple. First, we must guarantee low barrier access to medication based treatment for our patients with substance use disorder. Second, we need to ensure a smooth connection to ongoing care in the community. And third, we must emphasize a culture where our teams are equipped with the skills to help all patients who use drugs reduce the morbidity and mortality of substance use. That first goal, ensuring low barrier access to medication, is paramount. And if the goal is to truly make access to medication low barrier, what better way to expedite patient access than to include pre-hospital teams in our work? How can medics and EMS systems help protect patients against overdose? To answer that question, let's hear from our national EMS specialist here at Bridge, Dre Cantwell Frank.
EMS providers are a critical access point to healthcare for patients with substance use disorder, as non transport rates following a non fatal opioid overdose are at an all time high. EMS teams have an opportunity to relieve pain and suffering while simultaneously helping patients into recovery with life saving medication for opioid use disorder, or MOUD. Seeing the horrific effects of the opioid epidemic on our patients causes burnout and moral injury for many medics. MOUD offers a solution, empowering pre hospital teams to address the root cause of overdose and save lives. Addiction is a chronic, treatable medical condition. Using medication to treat addiction is evidence based, patient centered, and safe and easy. Naloxone saves lives too, but it's a temporary solution. A specific medication called buprenorphine, or BUP for short, offers patients sustained recovery and overdose prevention. BUP is a partial agonist on the opioid receptor. As a partial agonist, it does not cause respiratory arrest or overdose by itself the way that a full agonist like methadone, fentanyl, or oxycodone does. BUP treats opioid withdrawal and cravings, helping patients stop using opioids. Multiple studies have shown that BUP is extremely effective at decreasing patient mortality. And the number needed to treat with BUP to keep patients in treatment for OUD is 2. That's a better NNT than many standard practices in medicine, like giving steroids for a COPD exacerbation or aspirin for a heart attack. Starting BUP in the field results in higher rates of treatment retention when compared to just giving patients naloxone after an overdose. Imagine a patient that overdosed on an opioid, like heroin or fentanyl, and somebody calls 911. The patient is given naloxone and the paramedics arrive. Now that patient is alive, but they're also in withdrawal. In that moment, medics can start BUP, both relieving patient pain and suffering and literally starting that patient on a medication that is life saving. Think about it. A patient can go from near death to their best chance at life all in one encounter with an EMS team. That's amazing and an opportunity unique to those of us who work in emergency care. Medics in multiple EMS systems across the US have successfully implemented safe, easy to follow protocols to start patients in opioid withdrawal on buprenorphine in the field. Bup is given by medics as an oral dissolvable dose, and it must dissolve in the mouth. It does not absorb into the body in the same way through the stomach, so swallowing Bup leads to underdosing. Bup is FDA approved for adolescents and adults and is safe in pregnant and breastfeeding patients. It's really not expensive at around $4 a dose, far cheaper than many of the other medications on our rigs. And studies have shown that administration of Bup in the field does not significantly increase the amount of time we spend on scene with a patient. Because so many other EMS systems have already paved the way for this work, field tested sample protocols and corresponding medic training curriculum already exist and can be used for free from Bridge. So, implementing BUPE starts for opioid withdrawal at your EMS agency is easy. EMS BUPE brings hope and solutions to our medic teams and our communities.
That visual Dre painted of a patient going from near death after an opioid overdose to being actively in recovery, starting treatment, all in the same EMS encounter, that's amazing. Fighting the opioid epidemic in our country demands an all hands on deck approach. And clearly, our medic teams have the opportunity to be our patients' first line of defense. They are a critical part of the solution. The right thing for our patients is the easy thing for our ambulance teams. Paramedics can start patients on BUPE to treat opioid use disorder, instantly relieving pain and suffering and helping patients into recovery. Make buprenorphine for opioid withdrawal the standard for your EMS teams. And let's work together to save some lives.